Welcome to another deep dive. Today we'll be looking at some intense scenarios from, a paramedic textbook, kind of like real-life cases. We're going to see what makes treating children so different from treating adults.
Absolutely.
We're going to try and put you, the listener, right into the action. That's right. We'll go beyond the textbook and really get into the nitty-gritty of what it's like to be a paramedic, facing these challenges.
Okay, so first scenario, picture this. Perfect sunny day, you're on shift, and you're just kind of thinking about what you'll have for dinner later.
And suddenly your pager goes off.
Oh yeah, and the call comes in. You're dispatched to a home where there's a 4-year-old child, unresponsive.
Right away, there's a sense of urgency to this. The child is found near a bunch of pill bottles scattered on the floor, and the medications are metoprolol, glyburide, also oxycodone, aspirin, and Vasotec.
Wow, that's a lot of different medications.
Yeah.
And for a child that young, that's a red flag. What are the potential dangers of that kind of mix? It's a dangerous cocktail, to say the least. You got metoprolol, that's a beta blocker, slows the heart rate. Then there's glyburide, that's for diabetes, and can cause dangerously low blood sugar. Oxycodone, as you know, is a powerful opioid painkiller, can suppress breathing. Aspirin, even in small doses, can be toxic to children. And then Vasotec is an ACE inhibitor, another type of blood pressure medication. The combined effect of these could be life-threatening for a child.
And to make matters even worse, the textbook says that the child's pulse is weak, at 60 beats per minute. Their breathing is shallow, noisy, and there's cyanosis around the lips. That means the blood isn't carrying enough oxygen. What are your immediate priorities as a paramedic?
First thing, secure the airway. Make sure that child can breathe. We'll start providing ventilations, assisting the breathing to get oxygen into their system. At the same time, we're assessing for any other injuries, and we want to establish IV access for fluids and medications.
So it's all about those quick life-saving interventions. But you mentioned earlier that treating children is different than treating adults. How does that play out in this kind of situation?
A child's body responds to medications and trauma differently than an adult's. Their airways are smaller, more easily obstructed. Their metabolisms are faster. Their organs are still developing. So we have to adjust our approach. For example, the dosage of medications. We have to carefully calculate it based on the child's weight.
Yeah, that makes sense. And I imagine the equipment you use has to be adapted for smaller bodies as well.
Exactly. We use specialized equipment designed just for pediatric patients. Smaller breathing tubes, IV catheters, things like that.
Okay, so you've got the child stabilized. Now imagine that the child starts seizing.
Okay.
What do you do?
A seizure in a child that has potentially overdosed on multiple medications is a critical situation. We need to protect them from injury during the seizure. So gently position them, make sure their surroundings are safe. Continue to manage the airway, provide oxygen, and we may administer a medication like diazepam to try and stop the seizure.
So even with everything else going on, you have to be prepared for those new complications.
That's the nature of emergency medicine, especially when it comes to children. They can deteriorate quickly. We have to be vigilant, adapt our treatment plan as needed.
It sounds intense. Really highlights that specialized knowledge and skills to care for these pediatric patients.
Speaking of challenging airways, now imagine you're called out on a frigid winter morning.
Yeah. You arrive at a home and before you even step inside, you hear it.
Hear what? Don't leave me hanging. A harsh barking cough coming from inside the house.
Wow, I can only imagine. That must be concerning coming from a child. What could be causing that?
Well, that distinctive cough is a classic sign of croup, a common respiratory infection in young children. It's caused by a virus that inflames the upper airway, specifically the larynx and the trachea.
So when we talk about a child's airway being smaller and more easily obstructed, this is a prime example. What are you looking for when you assess a child with suspected croup?
So in this case, the call is for a 7-month-old infant. And when we arrive, we see that the infant is pale and struggling to breathe. Their skin is warm to the touch. And again, you see that cyanosis around the lips, indicating those low oxygen levels.
This little one's in distress. How do you approach treating croup?
The first step is to provide humidified oxygen,
Okay.
almost like creating a mini sauna for their airway. The moisture helps to reduce inflammation and make breathing easier.
That makes sense. So why wouldn't regular oxygen be enough? Why humidified?
Well, with croup, the inflammation is specifically in the upper airway, and the humidified oxygen targets that area more effectively. Remember, a child's airway is much smaller than an adult, so even a little bit of swelling can significantly restrict their breathing.
So you're trying to soothe and open up those tiny airways as quickly as possible. But what if that's not enough? What other options are there?
In severe cases of croup, we might administer epinephrine. It's a medication that acts quickly to reduce swelling in the airway. It's a powerful drug, but it can be a lifesaver in these situations.
I see. So you're constantly assessing the severity and adjusting your treatment plan. Sounds like a delicate balance between providing relief and managing the risks.
Exactly. And that's something we'll see again and again as we explore more of these cases. The decisions we make as paramedics can have a profound impact on these young patients. So we have to be knowledgeable, adaptable, and always focused on their well-being.
Well said. And unfortunately, our shift isn't over yet. This next call is one that every paramedic dreads. You're dispatched to a highway accident involving a truck and a car carrying two young brothers, ages 7 and 10.
It's chaotic, first responders everywhere, and the wreckage is significant.
Is every paramedic's nightmare. What's the situation when you arrive?
Tragically, the 7-year-old is deceased. The 10-year-old, he's conscious, but he's disoriented. And that's a serious concern in itself.
Oh, that's heartbreaking. Can you imagine what that must be like for everyone? The surviving brother, the parents, even the first responders?
It's one of the toughest parts of this job, dealing with the loss of a child. We have to try to compartmentalize to focus on the surviving brother.
You're in a situation where every second counts. What kind of injuries does he have?
He's got multiple traumas, abrasions and cuts all over his body. His abdomen appears distended and his pulses are weak.
So you're immediately thinking internal bleeding, shock. What are your top priorities in treating him?
In trauma situations like this, we talk about the golden hour. It's that first hour after a traumatic injury when getting the patient to definitive care, surgery, blood transfusions has the greatest impact on survival. We need to control any bleeding, stabilize his vital signs, and get him to a trauma center fast.
I've heard of the golden hour before. Why is it so critical, especially for a child?
Children can compensate for blood loss for a while, but they can crash very quickly. Their bodies just don't have the same reserves as adults. So that rapid transport to a trauma center equipped to handle pediatric trauma is essential.
That makes sense. But there's another layer of complexity here, right? The emotional impact of this accident. He just witnessed something horrific.
You're absolutely right. We're dealing with a child who is likely in shock, both physically and emotionally. So clear communication, compassion, reassurance. Those are crucial, even as we're performing these life-saving procedures.
I can only imagine how challenging that must be. To balance those urgent medical needs with the emotional needs of a child in that situation. It speaks to that incredible skill set required of paramedics, to be both highly trained medical professionals and compassionate human beings.
You hit the nail on the head. It's not just about the technical skills. It's about connecting with the patient on a human level, especially a child.
Okay, let's move on to a different type of emergency, one that can escalate very quickly. Imagine you get a call for a 6-year-old boy, sore throat that's rapidly gotten worse over the past few hours. He's drooling and struggling to breathe.
This raises immediate concern for epiglottitis. It's a serious infection that causes swelling of the epiglottis. That's the flap of tissue that covers the windpipe.
Epiglottitis? That sounds scary. What makes it so dangerous?
The danger is in the speed and severity of the swelling. It can happen so fast. And that swelling can completely block the airway, cut off airflow to the lungs. It can be fatal, especially in children.
So the symptoms you described, the drooling, difficulty swallowing, and noisy breathing, that's all because the airway is being obstructed.
Exactly. The drooling is because it's too painful to swallow. And that noisy breathing, it's also known as stridor. It's the sound of air struggling to get past the swollen epiglottis.
I'm guessing that when you arrive on scene like this, it's all about speed and knowing what to do. What's the approach to a potential epiglottitis case?
Our top priority is to keep the child calm. Any agitation can worsen that swelling and make things more critical. We provide humidified oxygen to try and reduce the swelling and transport them to the hospital quickly and safely as possible.
It sounds counterintuitive, but the textbook really emphasizes avoiding any invasive procedures like intubation, unless absolutely necessary. Why is that?
Because in epiglottitis, inserting a breathing tube could actually worsen the swelling and completely obstruct the airway. It's a delicate situation that requires a lot of judgment and a steady hand.
So you're racing against time, but you also have to be incredibly careful not to make things worse. It's amazing how much knowledge and experience goes into every decision a paramedic makes.
You're right. It's a constant process of assessment, reassessment, adaptation. No two cases are exactly alike, and that's especially true with children.
Okay. Let's move on to our final case for this deep dive. Get ready, this one is tough. Imagine you arrive at a scene where an 8-year-old boy has been accidentally scalded with boiling water.
It's a scene that nobody wants to see. The child has blistering burns over his entire chest and abdomen, his scrotum, and parts of his legs.
Just hearing you describe it is difficult. Is he conscious?
Yes, thankfully he's alert and conscious, but he's in excruciating pain.
So you've got a child in agony with extensive burns. How do you even begin to assess and treat something like this?
Our approach to any emergency starts with the ABCs: airway, breathing, and circulation. In this case, we need to check if he's having any difficulty breathing due to potential airway burns or swelling. Then we focus on pain management. With burns this severe, pain relief is crucial.
I can imagine. Seems like with burns, it's so much more to consider than just the immediate pain. What else is important when you're dealing with burns, especially in a child?
Burn severity is determined by two factors: total body surface area, or TBSA, affected, and the depth of the burn. In this case, with burns covering such a large area of the child's body, we're dealing with a potentially life-threatening situation.
Why is TBSA such a big deal, especially when it comes to kids?
Because children have a much higher body surface area to body mass ratio compared to adults, this means that a burn that might seem relatively small in an adult can be much more serious in a child. It can lead to greater fluid loss, difficulty regulating their body temperature, and a higher risk of complications.
I see. So even though the burns might not look as extensive, the impact on a child's body can be much greater.
Precisely. That's why we use a specialized chart, the Lund and Browder chart, to estimate that percentage of TBSA affected in children. The proportions are different from the chart used for adults, reflecting the unique proportions of a child's body.
That's fascinating. Really highlights how much we have to adjust our thinking when we're dealing with these pediatric patients. So given the extent of this boy's burns, what are some of the complications you're watching for?
Infection is a major concern with burns, especially when they cover a large area. We're also concerned about hypovolemia. That's a decrease in blood volume due to fluid loss from the burn. And this can lead to shock. And depending on the location of the burns, respiratory distress can also occur if the airway is affected by the burn or by swelling.
It sounds like you're managing so many different things at once, all while trying to keep this little boy as comfortable as possible. What's the next step in his care?
He needs to be transported to a hospital, one with a burn unit. These units are specifically equipped to handle the complex care required for severe burns, especially in children. They have specialized teams of doctors, nurses, therapists who can provide the best possible care.
This deep dive has been incredibly eye-opening. We've covered a lot of ground from overdoses and seizures to croup, trauma, and severe burns. It's clear that pediatric care demands a unique set of skills and knowledge. What are some of the key takeaways you want our listener to remember?
The most important takeaway is that children are absolutely not just small adults. Their physiology, their anatomy, their emotional needs, all of it's unique, and it requires a specialized approach.
And we've seen that play out in every single case we discussed. The way you manage child's airway, determine medication dosages, even the way you communicate, it's all different.
Exactly. And I think it's important to highlight that emotional toll these cases can take on paramedics. We're dealing with children in vulnerable and often traumatic situations. Compassion, empathy, and clear communication are just as vital as any medical intervention.
Well said. As we wrap up this deep dive, I want to pose a question to our listener. What stood out to you most from these cases? What sparked your curiosity? We've only scratched the surface of pediatric care, and there's always more to learn.
And that's the beauty of knowledge, isn't it? It's an ongoing journey of exploration and discovery.
Couldn't agree more. We'll be back soon with more deep dives into other fascinating areas of emergency medicine. Until then, keep learning, keep asking questions, and remember, every patient, every call is a chance to make a difference. You know, as we wrap up this deep dive into pediatric care, I keep thinking about all those subtle differences between treating children and adults. It's like a whole other level of expertise.
It is, it really is. And sometimes those subtle differences can make all the difference in the outcome. Let's revisit that first case. The 4-year-old, unresponsive, all those different medications.
Right, the metoprolol, glyburide, oxycodone, aspirin, and Vasotec. It was like a pharmacology quiz, just listing them all.
It was a complex mix, and it really highlights how critical it is for paramedics to understand those potential interactions between different drug classes,
Yeah.
especially in children.
So walk me through it. What kind of effects could that combination of drugs have on a child's body?
Well, you have to consider how each drug affects those different systems. Metoprolol, the beta blocker, can slow the heart rate and lower blood pressure. Glyburide for diabetes can cause dangerously low blood sugar, which can then lead to seizures and coma. Oxycodone, the opioid, suppresses the respiratory system, slows breathing. Aspirin can be toxic to children even in small doses and can cause bleeding problems. And then Vesotec, the ACE inhibitor, also lowers blood pressure.
So you've got multiple medications affecting the heart, blood sugar, breathing, blood clotting, all at the same time.
Exactly. And in a child whose organs are still developing and who may metabolize these drugs differently than adults, these effects can be amplified.
It's like a domino effect.
Yeah.
One problem triggering another. It really underscores the importance of gathering as much information as possible on scene.
Absolutely. Talking to caregivers, looking for those medication bottles, any clues that can help us understand what the child might have ingested is essential.
It's like detective work on top of providing medical care.
You could say that.
Let's shift gears back to that croup case with the 7-month-old infant. We talked about how epinephrine can be a lifesaver in those severe cases, but it's a powerful drug. Are there any risks involved in using it on, such a young child?
Well, epinephrine is a powerful drug, and like any medication, it has potential side effects. It can cause a rapid heart rate, anxiety, tremors. But in a situation where a child's airway is closing off due to the croup, the benefits of quickly opening that airway, they far outweigh the risks.
So it's a calculated risk, but one that you're trained to assess and manage.
That's right. We carefully calculate that dosage based on the child's weight, and we monitor them very closely for any adverse reactions.
Now, that highway accident with the two brothers, where one child tragically died and the other was seriously injured, it's a scenario that brings up so many questions. What if you're in a rural area, far from a specialized trauma center? How do you make those critical decisions about where to take a seriously injured child?
That's a tough situation, and it's one that paramedics in those rural areas face all too often. We have to weigh a lot of factors: the severity of the injuries, the capabilities of the nearest hospitals, the time it would take to transport that child to a trauma center.
So it's a judgment call based on experience and the specific circumstances.
Exactly. We have protocols and guidelines to help us make those decisions, but ultimately it comes down to using our knowledge and training to determine the best course of action. Sometimes that means stabilizing the child as best as we can and transporting them to the closest hospital, even if it's not a trauma center. Other times it means calling for air transport to get that child to a trauma center faster.
It sounds incredibly stressful.
It can be. But we train for these situations. We have a network of resources to support us. We also rely on each other, sharing knowledge and experience to make the best decisions for our patients.
And that brings us back to that burn case, the 8-year-old boy scalded with boiling water. We talked about how children have a different body surface area to body mass ratio than adults. Can you explain how that affects, how you assess and treat burns in children?
Sure. So we use the Lund and Browder chart to estimate that percentage of TBSA, total body surface area, affected by a burn. The proportions assigned to different body parts on that chart are adjusted for children. For example, a child's head and neck make up a larger percentage of their total body surface area than an adult's.
So a burn that might look relatively small on a child could actually represent a larger percentage of their TBSA, making it more serious than it might appear.
That's right. And that difference is critical in determining the severity of that burn and the appropriate treatment. Fluid resuscitation, for example, is crucial in burn patients to prevent shock, and it's calculated based on that TBSA. We also consider the depth of the burn, first degree, second degree, or third degree, because that affects healing and the potential for complications.
It's amazing how much goes into assessing and treating burns. It's so much more than just putting on some ointment.
Absolutely. It's a complex process that requires specialized knowledge and skills.
Well, I think we've covered just about every aspect of pediatric care in this deep dive. We've explored some really intense scenarios and learned a lot about the unique challenges of treating children in these emergency situations.
It's been a great discussion. I hope it's given our listener a better understanding of the dedication and expertise of paramedics who care for children in their most vulnerable moments.
I agree. And for our listener out there, we encourage you to keep learning, keep asking questions. The world of emergency medicine is vast and constantly evolving. There's always something new to discover. Until next time, stay curious, stay informed, and stay safe.